Welcome back to Research America's 2020 National Health Research Forum. We're going to dive into our next panel discussion in just a moment, but I want to share some tips that I think will help you enjoy your virtual conference experience even more so. So you can chat with other meeting participants using the chat feature. You can also ask questions of the panelists by using the Q&A feature. And don't forget to visit our exhibit hall booths. We have a video vault with all of our really compelling, pithy 23-1 videos. We have a Research America booth where you can download our reports, polls, fact sheets, and we even have a swag bag where you can download references and then email it to yourself when the event is complete. Of course, if you need help, you can click the info desk link in the menu bar at the top of your browser where you can find live tech help, or of course, email the address at the top right of your screen, for on-demand tech support at any time. All right, well, let's now move to our next very important conversation. It focuses on how to combat the disturbing racial and ethnic disparities in COVID-19 infection rates and outcomes, as well as longstanding and equally disturbing disparities in health and healthcare. Our moderator is Sudip Parikh, Chief Executive Officer of the American Association for the Advancement of Science and Executive Publisher of the Science family of journals. Our 5 very distinguished panelists are the Honorable Dr. Louis W. Sullivan, former U.S. Secretary of Health and Human Services and chairman of the Sullivan Alliance to Transform the Health Professions. Dr. Vivian Pinn, the founding director of the Office of Research on Women's Health at NIH and senior scientist emerita at the Fogarty International Center at NIH. We're also joined by Dr. Patricia Doykos, the director for the Bristol-Myers Squibb Foundation, Dr. Elena Rios, president and CEO of the National Hispanic Medical Association, and Dr. David Williams, the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. You can post questions for the Q&A portion of the discussion by using the Q&A feature. Let's get started. Sudip, I'm turning it over to you.
Thank you, Jenny. Thank you so much. Good afternoon, everybody. Thank you for taking the time to join us for this conversation on how to make sustainable progress towards health equity. First, I want to thank Research America for the incredibly compelling agenda of which this panel is a part. The panel gathered before you is extremely accomplished, and based on them and their knowledge, we are not going to drop the torch when it comes to being compelling, thought-provoking, and solution enabling. This group is going to keep it lively and really come up with some solutions, I think. COVID-19 has made the life and death disparities in health research and health care even more visible. And the images and the numbers are unavoidable and frankly undeniable. But let's be honest, we as a health research community have been aware of health disparities for a long time. We have been talking about addressing health disparities for a long time. And our discussion today is going to explore what actions we can execute immediately to mitigate the disparities of the impact of COVID-19, and very importantly, how do we translate this undeniable visibility of this issue? How do we translate that undeniable visibility of this issue into concrete progress against the entrenched inequities in health research and health care? That is it's really profound, even though it's so simple. The question is simple, and yet addressing it has been such a challenge. And I'm going to dispense with some broad introduction after that, because frankly, we should get to our panelists. Their bios are in the auditorium, and I suggest you go there, and you will recognize that I am being a little disrespectful because I'm going to call them by their first names, even though I'm probably not. I'm not in the same league to be able to do so, but I'm going to do that anyway to keep the conversation going. So I'm going to kick off the discussion really by asking each of them the same question, which is, what is a strategy that our nation can pursue to advance health equity? And it's such a broad question. I'm really hoping they'll highlight the areas in which they have been working and in which they hope to have an impact. And then we'll dive into some of the areas around healthcare research, healthcare in general, that are both suffering from disparities and what we can do. So I'm going to start with Dr. Pinn. I'm going to say Vivian. I'm going to start with Vivian, please.
Thank you. I'll be brief, hoping we'll get back to be able to discuss some of these. But what first struck me when we heard about the pandemic and how it was affecting individuals with my history in women's health was the fact that there was a greater mortality for men than for women. So we were looking at gender issues, but then all of a sudden it became apparent that the brown and Black populations were those who were suffering the greatest morbidity, greatest mortality, were the ones who were most likely to end up in ICU. And then that raised questions and began to ask, what are the data, and found out that in fact, there were no national collections of disaggregated data. And I was told by a number of hospitals that no city agency, no state agency, and no federal agency had even asked them to collect that data. And with my background and focus on research, I'm thinking, how in the world can we do something about eliminating this pandemic if we don't even know for sure who is affected, and looking at it in terms of different populations that are affected? And that becomes even more important when we think about where we are now, looking at the vaccines and what is commonly recognized as the lack of inclusion of those who are most affected by the pandemic in this country anyway, not being adequately represented in clinical trials. So there are many facets of that have really had me passionately paying attention to what's going on and speaking about it. And I'll stop with that. Those are some of the major issues I hope we'll get to discuss more.
Vivian, I'm looking forward to that. Talking about how do we address this if we can't even get at the data is, I think, a central question that we'll come back to most definitely. Lou, if I may turn to you.
Yes, I think in trying to address the issue of health disparities, really it's quite complex, but there are a number of factors here. I'd say some of the ones I would say immediately that we should use would be working with leaders in the community, because one of the problems in our health system is lack of information and lack of trust. And I think the events of the last several months really have heightened that problem because we now are looking forward to having a vaccine, hopefully in the next few weeks or few months. But we have a large segment of our population who are saying that they are not going to utilize that vaccine because they don't trust the process. So I think that's a real problem. I think in the health professions, we need help. We need help from community leaders such as teachers, ministers, heads of YMCAs, boys clubs, girls clubs, etc. So we need to have those trusted voices in the community to work with us in the health professions, to give the information to the community, to convince them that the products that will be coming out are genuine and will be helpful. So that's one thing. The second is more long-term, and that is increasing diversity in the health professions. Because I often say that an enterprise in health delivery involves two basic things. First, having a health professional who is well-trained, who has the knowledge base, who has the scientific facts, who has the expertise. But that by itself is not enough. That person needs to also have the communication skills, the ability to develop trust in the individual being served, because you have to have both scientific knowledge and understanding of the individual to have the value system, the history of that individual, knowing that, so that by developing strong communications, you develop trust. When you develop trust, then that individual will understand, will participate in the discussion, in the dialogue, will come back for a follow-up visit when it's required, will ask questions when they don't understand, and will really become a partner with the health professional in seeing that that individual gets a good health outcome. So it's both having knowledge and good communications, good trust. So those are some of the things. There are many, many others, but those are the ones I would cite at the beginning.
Thank you, Lou. I'm looking forward to coming back to all those issues. Trust is something that we've talked about throughout yesterday and today, and I'm looking forward to talking about it here as well. Elena, if I could turn to you.
It's great to be here. I think that for the National Hispanic Medical Association, we actually closed our office in mid-March. All the staff went home, but in talking to our board of directors, and mainly doctors, a few public health also, very interested in sharing knowledge from the front lines. And we set up a monthly webinar series, not doing Zoom before. This was, so this has really been an experience for a nonprofit organization to be able to share across the country what was going on. And we made it a point to have topics coming from Latino doctors taking care of the Latino community and African-American community, poor white communities, farm workers, urban, Texas, border, California, New York, and talking about different issues that came up from the intensive care units with death and dying to the mental health and anxiety just of elderly people in our families having to stay home, to just how do you talk to your kids. And I have to say, one of the most important lessons was that the doctors started having to do their own thing and realize, and we're talking community doctors that started doing their own testing, started calling their own patients to reassure them, and started working with the public health departments to be able to connect on how they could be of service when many of our doctors that are in communities had to close down their practices. The dentists had to close down their practices. So I think that for us, there's been a lifelong learning experience through this. And I would hope that we could talk about how our communities do need the trust and the messengers from our healthcare leaders on the front lines. And I have to echo what Dr. Sullivan said about the importance of diversity in the healthcare profession. We realize how much we lack in this country of this kind of knowledge.
Thank you, Elena. David, if I can turn to you.
Sure, I completely agree that we need to work on ensuring that everyone has access to medical care and receives high quality medical care. But my emphasis is not on medical care. Medical care alone will not solve the problem. If you want evidence, look at England. In England, the racial disparities are even larger than in the US. And everyone has access to the National Health Service, but Blacks in England are 4 times age-adjusted rate, 4 times higher death rate from COVID-19 than whites in the UK. So it illustrates that even in the presence of free access to medical care, we are still seeing very large racial disparities. So it points us to, we need, public health likes to say today that your zip code is a stronger predictor of how long and how well you will live than your genetic code. Emphasizing the point that the opportunities to be healthy in the places where people spend most of their time are the big drivers. These social determinants are huge drivers of health. And I think one of the things we need in the United States is a Marshall Plan for disadvantaged communities that would create opportunities at a neighborhood level and access to schools and access to good jobs and access to high quality housing and living conditions. That is a priority in terms of really making sustained progress and building to reduce these chances of disparities in the future.
Thank you, David. We will definitely, some intriguing data you're talking about there. I'm looking forward to digging in a little bit. Patty, turn to you.
Thank you, and thanks so much for including the Bristol-Myers Squibb Foundation in this panel. It's good to see friends we've worked with before on the panel. You know, for us, we are really focused on innovation in R&D for health equity. So the status quo in terms of healthcare delivery, public health services doesn't work effectively for many populations. So digging into why is that and how can we disrupt that and create new models of care that are effective, new models of public health information, new models of getting mitigation to communities so that they are actually effective and at the end of the day achieve the kind of health outcomes and get to that North Star that we all hope for, which is optimal health for everyone and leaving no one behind and leaving no one out. To resonate with what David has said, one of the principles of the projects that we do fund to do R&D in this space really brings together clinic community partnerships. So there are barriers inside the clinic in terms of healthcare services and how they're delivered in the workforce and so on. So overcoming those barriers. But as David has said, there are many barriers outside the clinic too, whether patients cannot get to their appointments, whether they need better health information, whether they need somebody trusted from their community to come to them, talk with them about getting some kind of screening, understanding a care plan perhaps that they have, addressing issues like food security, housing, these other forces that crowd in on patients and make it impossible for them to access the care that they need. So you can back up the care system tomorrow, but all these other factors are in place. So we really look to help grantees come together as partners to community supportive services, working with healthcare delivery, not just to deliver services alongside each other for the community, but truly take almost a customer service type approach and make it easy for the patient to get access to all the supports that they need so they can securely move through the continuum of care and receive high quality services and then achieve optimal health outcomes.
That's terrific. Thank you, Patty. Well, you've all given us a lot to, several different threads down which to burrow. So why don't we do this? Why don't we start with health research and talk about data. Vivian, you brought up the fact that data is not always easy to access. And Elena, you brought up the fact that you're bringing frontline knowledge to the community was so impactful. Maybe we can dig into that just a little bit. Vivian, what types of data weren't available and are they available now?
Well, there are now efforts to collect data, and I believe eventually CDC began to ask for data by racial and ethnic groups in addition to by sex and gender. But fortunately, some medical centers were beginning to collect this and look at their patient populations, but many were not. So when we go to look at what populations have been affected and how deep are the disparities, we really don't have good information. There's one area that was pointed out to me by a medical center, though, that I will acknowledge is something that probably we can't do much about. And that is if we look at the drive-by testing, the people who've been trained to do drive-by testing have been trained to do that testing using the swab. But in that process, there's difficulty in asking them to collect data. So we're probably missing some of the data in terms of those who get tested that way. But beyond that, fortunately now, I think there has been a greater recognition, especially with all the scientific literature and public information about the disparities, that it's recognized that we need to recognize which populations are being affected, which ones are suffering the greatest morbidity, which ones are suffering the greatest after effects, which ones are suffering the greatest economic problems, and which ones are suffering the greatest mortality. But then also looking at data, if we look at the clinical trials, and this can get to be another area which I think is sort of the hot topic of the moment, that looking at inclusion, I thought we had settled many of these issues about how to reach out and include diverse populations back in 93, 94 with the implementation of the NIH policies for the inclusion of women and minorities in clinical trials. And it's almost as though people have forgotten what should have been institutionalized now, which is how do you go about recruiting other populations and making sure you've got diversity. Clinical trials should not be designed based on census data. It should be, the clinical trials should be designed based upon the prevalence of the condition being studied in the population, and that's how you should construct, how you design your study. And obviously, that's not happening because the percentages we're hearing about inclusion of minority populations, those most affected by this virus, are not the major subjects in the clinical trials. And that's going to lead to a lot of questions. Dr. Sullivan brought up trust, others brought up trust. People want to know, and they're smart, not just in the scientific and medical community, but our general population, grassroots level. They want to know, how do I know this vaccine or this medication or this intervention is going to work on me? Were people like me part of the test group? Can I be reassured that this is going to be safe for me? And getting a little bit away from data, but sort of the dilemma that some of us are having right now, which is we've spent years convincing minority populations to be included in clinical studies, and most often, once they get the information, understand what it's about, they're looking to be part of studies. But if we're now dealing with public information that suggests that some of these vaccines studies are not including populations that look like them, and also that some of the studies may not go to a complete conclusion as they usually are for phase 3 clinical trials, can they be tested? So do we, encouraging our populations and communities to be participants in these trials or to take the vaccine, which we want, which hopefully would protect them, at the same time, if we have incomplete data, are we then exposing our communities to unknown as yet risk? And this is the dilemma that I see a lot of physicians and community leaders of color facing at the moment.
Mm-hmm. Elena, do you see those? Do you see that same dilemma? Do you?
Yes. Yeah, I totally agree. And honestly, right now with the clinical trials, we have been involved with announcing to our membership and to announcing to, you know, in every webinar that we're doing, and we're about to start chapter webinars, you know, in the 20 chapters that we've got across the country. We are encouraging diversity in these clinical trials because it's so important to understand the impact on our communities. And despite historical, you know, Tuskegee and you know, for Latino women being sterilized in California and Puerto Rico, I think that we have to get the message across of how important it is to know the impact on our communities. And I was just floored to realize that just with COVID-19 statistics coming out of CDC, they only have 49% of minority data. And, you know, I agree with Vivian. I didn't think that would be the case in 2020. So yes, we do need more working with our leadership at the ground level to get more people enrolled. We're also working with All of Us research program at NIH. And again, another type of data sets that will be available for the next generation of researchers. To have diversity is going to be very, very important.
David, hearing that, you know, you talked a little bit about access not being the only critical factor. Dig a little deeper into that for us. What are some of the other data points that you're looking at in terms of COVID-19 and how it might translate to the broader issue of health disparities?
So if we look at the populations that are most disadvantaged, there are populations that are markedly lower in income and dramatically lower in wealth. So African-American households earn 59 cents for every dollar of income that white households earn. That's 2018 data. Latinos earn about 70 cents for every dollar of income that white households earn. And if you look at wealth, the wealth gap, African-Americans have 10 pennies for every dollar of wealth that whites have, and Latinos have 12 pennies. So when you are low income and in a struggling economic environment, although the entire country is in the storm of this pandemic, those who are low income are in different boats than those who are better off. So the living conditions, working as essential workers where you can't work from home, you can't protect yourself, oftentimes living in more crowded conditions, and many who lack access to resources, and even the stimulus funding that was provided. Many poor communities did not participate at a high level in receiving additional economic resources. And one of the things we need to keep in mind that the impact of the pandemic, not just on the health of the population, and we can think of the long-term impairment that some who have survived will have, but we also have to realize that it has disrupted the sources of income within minority communities. And so it's also the loss of livelihood. So the challenges that the communities face before COVID are now even exacerbated in the post-COVID era. And that's why we need to think of how we can provide additional resources right now so that many poor households in America will not lose access to their utilities because they don't even have money for the rent, and have access to food and access to stable housing. So the economic impact is enormous, and we need to act for those essential workers who are keeping the economy running to ensure that they have what it takes to not only survive, but to thrive.
Thank you. Lou, you've been at this a long time. Are those issues new to us? You know, we've tried mitigations for many years. What is the start? Trust is certainly part of it, but what else?
Sure. No, these issues have been around for a long time, but what the COVID pandemic has done has brought them to the attention of the American public in a dramatic way, much more so than has been the efforts that many of us have undertaken over the years. So that certainly is important. I'd like to add a couple of comments here too, in terms of how do we really dig out of this hole that we are in terms of the threat to our society from this pandemic. We mentioned data and research, and I agree with everything that has been said, but I'd add another dimension to it so far as research is concerned. We know that of our faculties of our health profession schools, less than 5% are minorities. We need to work to have programs to increase that number. There was a study that many of you are aware of that was published by Dr. Ginter and her colleagues that was in Nature in 2011. That study showed the following. A first-time applicant for R01 grant from NIH, if that applicant was white, had a 30% chance of having a positive outcome from that application. If that applicant was African-American, he had a 13% likelihood of success, less than half as likely. That was a very dramatic finding. And of course, NIH has instituted a program of mentoring to try and address that. But in my view, like so many things, what has been done is far from what is needed. What NIH has done has started, but we need to have a lot more. Now, that is important because when you have diversity among your research team, you also can have a diversity of ideas, of experiences, of perspective. So that will add to the mix of input in designing a research study to get outcomes that are meaningful. But it also has the impact of having the public trust the information to a greater degree. If they see that this research team has not only whites, but has Latinos, has African Americans, has Native Americans, they indeed will have some greater confidence in the output from that group. So the issues that we are trying to address, some will lend themselves to some immediate actions, but others will be more long-term. We're talking about developing more researchers. We know that's a process that takes years, but we need to start, and we need to start now, and we need to do it in a robust way. This is so tied up in other things. Why is it we have so few minorities? Well, as David has mentioned, minorities have lower incomes. Students going to health profession schools today end up with debts when they graduate of $250,000, $300,000. When you tell a high school student who says that he or she is thinking about being a doctor, that they have to look forward to graduating with a debt of $250,000, that for a lot of students is an immediate turnoff. because they may come from a family where they are one of 4 or 5 siblings. The family income may be $35,000 or $50,000. I'll give you this data. The AAMC has shown that the average income of medical school families going into medicine today is more than $135,000. Well, the average family income for African-American families is $40,000 or $45,000. At Morehouse School of Medicine in 2014, where we have a special focus in trying to get low-income students, we found that the average income of our entering class in 2014 was $70,000. In that year, average family income for African Americans in general was $35,000. So even with the efforts we had underway at Morehouse, our students' family income was twice that of an average Black family. So as we try to address these issues, this is a good example of how one issue is linked to another. I'm pleased that we are beginning to see things such as the program at NYU to have an endowment that'll provide income for the students so that they can have a health professions experience without having to go into debt. This student debt problem is relatively new. I went to medical school in the mid-50s, so I'm of a different generation. Student debt was not an issue then. I didn't have to worry about debt, neither did my classmates. What happened? Well, what happened was in the mid-70s, doing a budget exercise to try and reduce the federal budget deficit, a lot of programs such as exceptional financial need programs, the National Health Service Corps Scholarship Program, a number of other programs were greatly cut back with the statement that medical students, dental students, and other health profession students can really pay off their cost of education by taking loans and repaying those from practice earnings. That's a philosophy that works well for a student from a wealthy family. But for a student who comes from a low-income family, that seems to that student to be absolutely preposterous. Why would they, from a family earning $35,000, $40,000, risk incurring debt of $250,000? They have questions as, well, what if I don't really get through? If I have circumstances that I drop out and I then have this debt. So we need to have strategies to increase the number of health professionals from minority populations that will not incur the tremendous debt. I see it as an investment in our future, in our manpower needs for the country. We need to have the philosophy that to have a better society tomorrow, we need to invest in our young people today. So that's another factor that we have to consider in addressing the health disparities problem.
Here, Lou. And I can, you know, from the AAAS perspective, we see those same issues for scientists. Even if you're getting a graduate fellowship of, you know, $20,000 a year, you shouldn't have to have a family safety net in order to pursue science. That shouldn't be out there. So you've raised some powerful questions. The group has raised powerful questions. In our last 20 minutes here, I want us to focus on some of the solutions and ideas that you all are pursuing. And Patty, I'm going to turn to you first. You've talked a little bit about some of the things that the VMS Foundation has done. You've talked about your partnerships with some of the folks even on this video conference. Tell us about those, and I'm going to come around to each of you. David, I'm looking forward to hearing about the Marshall Plan. We have it sounds like we have some maybe provocative solutions that this group is willing to offer up, and I want to hear those. Starting with Patty.
Thanks. So just continuing the conversation that Lou started, last August, or just last month, our foundation announced a new $100 million initiative to train 250 investigators of color and from diverse backgrounds. So these are not fellowship programs, these are after fellowship. So it's a real career development program that will protect their time in order to, you know, be paid to protect their time to actually gain the skills to become clinical investigators. So not only having mentors, but also different kinds of exposures like to the NIH, so you can submit more successfully for your first grants there, exposures to industry as well, and other groups that are doing different kinds of research, so that it will be a really powerful program to go into that piece. And it really is a layer cake in terms of addressing and really making movement on diversity in clinical trials. But even beyond that, developing the science, as Vivian was saying. So you can have diversity in clinical trials. What is the science coming out of that? What should the research agenda be? What will that understanding be as well? And between the foundation and also on the company side, we're addressing better outreach and engagement, certainly with patient populations who are heavily affected by our strategic diseases. So not taking census data, but taking geospatially mapped epidemiological data, and then really going into those communities where there is the burden to engage with patients, using their leadership, using the strengths of the community to say, how can we work together to bring this information as a trusted source to them. So you have the patients, and then you have the investigators. I talked about what we will be doing in terms of developing a much more diverse cadre of investigators to do all kinds of research. And then there's site selection. So, you know, going to the same sites over and over and over again because they have very strong clinical trial capacity is one thing. What about the clinical trial deserts that are out there? And as we know, it is such a barrier for many patients, even if they are fortunate enough to be informed that they could participate in a clinical trial, it may be so far away with the demands of the regimen that they cannot participate in it. But if we can bring clinical trials closer to them and upskill community hospitals, safety net hospitals, creating strong relationships between those clinical trial centers who do this every day and have extraordinary expertise on them, and having them share that with community-based hospitals and clinics. This will be another way to solve the site problem. So doing all of these pieces together, as Lou knows well from the HIV/AIDS response, it's coordinated action that actually moves the needle. And so addressing the different sides of the problem together, it seems to be a very important way to take it forward. So that's sort of on the research side of things. And then I think in terms of, you know, health equity, Vivian talked about segmenting the patient populations, really seeing who is impacted. One approach that we have taken in our grants is sort of a quality improvement approach. And the Institute for Healthcare Improvement has been a partner with ours on this. They've created a framework to help healthcare organizations do better in terms of health equity, deliver more equitable care, achieve more health equity and optimal outcomes for their patients. But it starts with, frankly, seeing who you take care of, and also asking who isn't here and who should be here and how do we get them here. So it's not only saying, you know, who do we take care of, but also looking beyond that. And quality improvement, I think, really speaks to variation in care, which is what inequities are. There's a variation, there's underperformance somewhere, and really using the tools of quality improvement to get in there and understand, segmenting the patient populations, understanding their experience throughout the full continuum of care, and then using tools to get in there and improve. This is where the R&D comes in. You might have a different idea about how a lung cancer patient is screened, attached to diagnosis, and then brought through treatment, but you know that there are going to be a different set of supports, again, inside, outside the clinic, for patients to achieve that equitably across the population base that you take care of. So it's we're very research oriented at the foundation, both in building up capacity for research, definitely, and then also digging into the health equity issues that are out there and using tools that have been long used for problem solving to close the window on the gaps that exist.
So, Sudip, can I just comment? I'd like to commend Patricia for her presentation. I'm very pleased to hear about Bristol-Myers' commitment to training investigators. And one of the things that's happening with this COVID pandemic, I think we're seeing things such as support for Black colleges that has been announced, the recent Bloomberg gift to the 4 Black medical schools, and I think we'll see others like that. But I think the investment in our society and investment in our young people, I see as a responsibility not only of governments, but the private sector as well. So I think that's a great example. So I just want to commend you and your colleagues at Bristol-Myers for doing that and challenge the other pharmaceutical companies to step up as well.
Absolutely. Vivian, you've been tremendously influential in government in increasing the number of women and minorities in research. What do you hear of that, and what more should be done?
Well, I think, and especially thinking in terms of these of the current atmosphere we're in, that it is important to have, like to say, the communities you want to target should be involved in the design of the study, not just with being investigators, but also if you're going to reach out to a community that's involved by the condition you want to study, you should reach out to members of that community to let them know what you're designing and having them know why it would be a benefit to those communities. You need to make sure that communities don't just see someone that looks like them as a recruiter, but has already been stated by several earlier, that there's diversity among those who are designing the studies. I want to pick up on something that Patty said, which has concerned me since I've left NIH, where when we were really focusing on women's health and minority health with the new Institute on Minority Health and Health Disparities, thinking that in one way to increase the number of researchers, diversity of researchers, both women and those of color, that if we got them interested in some of these issues, that they would then get into research in those areas. And I happened to see a statement made by someone at NIH that I hope was not representative of the current thinking of NIH, that said maybe one of the reasons that our investigators were not getting funded at the level of others is because of the topics they chose to study, such as women's health or health disparities. I've been fuming about that ever since I saw that, because to me, that misses the point. So I think if nothing else out of this pandemic and what we're seeing in terms of research, we need to make sure that not just NIH, but any government or private funders are recognizing the importance of studies to look at all aspects of health disparities, and that they should be priorities. You don't take away from technology studies, you don't take away from genetic studies, but you have to recognize that studies of contributors to health disparities are as important and should be funded also. And I wanted to add another area we hardly ever mention when we talk about community outreach. Obviously, I've been engaged in lots of discussions related to this pandemic. And one area we don't talk about, we talk about the barber shops, we talk about the beauty shops, we talk about the churches, but we have to remember that community pharmacists in drugstores and in grocery stores where they're pharmacists, they're handling a lot of information, a lot of questions that come to them because they're seen as someone people go to. And I know from talking to several, those who are pharmacists, that they're being asked questions. Where can I get the vaccine? Or tell me, how do I get the test for the virus? So I want to make sure we include them. But it comes back to sharing of information, loose stress communication, that's very important. But also, Lou has also stressed in others the need for increasing our number of diversity of our healthcare, not just researchers, but providers, but also in recruiting more into clinical trials, really need to work with the population of diverse physicians, because they're often the first person that's going to be consulted. I know there have been calls into the office of the National Medical Association, which is composed of primarily African-American physicians. And I bet Alina has had the same thing, saying, I'm so confused by what I'm seeing. Can somebody tell me, what do I need to know about this virus? So I think there are many aspects of not just research, but of healthcare and the implications that show there is a need for better communication, for broader involvement at all levels, from the research spectrum to implementation, and also having a clear national message. To me, the major problem we've had with this pandemic is there has not been a clear national message or a clear national plan about how to attack it and understand it. And the confusion is helping to contribute to the mortality. That's my personal opinion.
It's a strong and good opinion. Vivian, your message about the language from NIH is just, it's so illustrative of the point. that not recognizing that health disparities actually would have research in health disparities would have a huge impact on the health of the nation is really unfortunate. Elena, I'm going to turn to you then David. Elena, please.
On the chat, I saw a comment about President Trump now saying that we don't need diversity anymore. It reminds me of the comments about not needing affirmative action anymore. And I have to say that I'm very happy coming from California. I actually live in DC, but coming from California, that we have a Proposition 16 on the ballot in California that it's going to decrease or delete Prop 209, which was the horrible initiative that came out of California to stop racial use, as a factor in admissions to higher education. And it really scared off a whole generation of Black and Hispanic and Native American kids. And there's been a new study, excuse me for not knowing where it came from, the study that just came about that the impact of Prop 209 actually decreased the salary levels and our family incomes of Black, Hispanic, Native American kids that could have gone to college in the California system, which was probably one of the most accessible college systems, the junior colleges, the UC system, and then the private schools always having a lot of financial aid in California. So I have to say, we really, what we're doing with our organization is having mentoring, starting with the college pre-health students, mentoring of medical students, and we're using the Hispanic doctors just ahead of them to be their mentors and speakers. And we've actually gotten a funded grant from Office of Minority Health to do a research study to document the difference in a control group versus a mentoring group, which I think is actually showing tremendous success. And we've been holding 6 pre-health conferences a year for about 4 years now across the country. And I just want to say that there's a lot of interest in our communities to get into healthcare, despite the debt, despite the income problems. But you know what? There's a real lack of knowledge. College students do not know how to become a doctor, do not know how to become a scientist. And it really is up to our organizations to help develop that next generation. One more plug for us is we've been doing scholarships. And I think that's, the little bit of scholarships that we can do really go a lot with our families. Mm-hmm. So I think there's a lot to do, and we're here to help.
Thank you, Anna. You've spoken about scholarships. David, you mentioned something called a Marshall Plan for these communities, for our communities. That speaks of a scale that is bigger than many things we've talked about. Could you elaborate on that, please? And then I'm going to turn to audience questions. So please, I know we've seen a lot in the chat box.
Sure. I think we need to make a national commitment to address the underlying causes of these disparities. The good news is the data is clear that if we made that commitment, it would literally save society money. We have high quality scientific evidence that shows investments in early childhood, for example, not only improves academic performance, but health and risk factors for heart disease in the 30s are markedly lower in a randomized controlled trial where some kids, poor kids, 80% African-American, got a high quality early childhood experience, birth through 5. We have evidence that if we improve neighborhood and housing conditions with no health intervention, we improve health. And if we can provide a job is a good strategy for promoting health and providing educational opportunities for others. Purpose-built communities is one example of a program that has taken disadvantaged neighborhoods and transformed them and transformed the schools and markedly reduced the crime rate. So we actually have examples. If we only use all the knowledge we already have, we could make a big difference. And research consistently shows that these investments will increase the productivity of our population. It will increase our global competitiveness. So it makes no sense that we are not making those investments that will improve our population and also improve our economy.
Thank you, David. It feels like what you're saying is that known the solutions. We know the solutions. We need the national commitment to get there, and perhaps
political will to do.
COVID-19 is the spur. All right, fascinating conversation. Caitlin, I'll turn to you for questions.
Thank you, and appreciate that Marshall Plan details, since we did get a couple of requests for additional information on that. So we've received a few questions around a similar theme, which is about constant going back to staff and saying we can't do the same thing over and over again and expect different results. So how do we move forward and get tangible results? And also, is there something that isn't getting through to policymakers about or public health officials about health equity that has prevented progress? So I'll let Sudip direct traffic on that question.
Sure. I want to turn to Vivian's got her hand up, and then maybe Lou.
Yeah, I should yield to Dr. Sullivan, who really got me into all of this national policy issue. But I wanted to add one thing in that, and that is, hopefully, I mean, I'm really sorry that we're seeing all this health disparity brought about by the pandemic. But if nothing else, it has really focused the national consciousness on the fact that health disparities exist in this country and the impact that those health disparities can have on all of our communities, regardless of where you are. There have been a number of panels and discussions recently saying that perhaps racism should be considered as one of those social determinants. If you don't want to refer to it as racism, let's think about it in terms of perhaps what I like to characterize as traditional stereotyping, traditional stereotypic biases, which I think is people are more receptive to that, even whatever you call it, sexism, racism, homophobism, or whatever. But I think seeing the effects on our communities now, that maybe some of these things will be taken much more seriously. We're seeing institutions, we're seeing schools of healthcare schools, we're seeing others put in place programs to make sure that people are understanding what health disparities are and looking at the factors that contribute to that. So I think if nothing else, anything good comes out of this is that there will be more of an awareness and therefore more attention to not just taking that course or understanding that health disparities exist and forgetting about it, but recognizing the impact they have on all. And I'll yield to Dr. Sullivan, but I just wanted to get that point in.
Well, thank you. I would add, I think the underlying concept that I would like to stress that certainly I think supports what David Williams and others say is this: we need to empower minority communities and poor communities to work with the health professions.
Yes.
We need to see that they see themselves as part of the solution rather than being the problem. So we've always had this benevolent view that we're having the scientists or the health professionals come to the communities, and certainly we want to have good science, but people in the community are very bright. They know what their problems are. They need to have the resources and the tools to help solve them. So I think involving the community in a way that they are empowered to help provide the solutions is very important, because we want to develop health habits that don't go away once the problem is solved. We need to improve the health of our citizens by a number of preventive measures and improved health behaviors. So I would say all of those are very important. And I think the other thing I'd reinforce that Dave Williams mentioned, many of these things we do will result in better economic outcomes later. Maternal and child health programs result in people, when they are grown up, being more successful, not only in supporting themselves and their families, but also contributing their taxes to our society. So we need to show that investments in health over the long term really pay off, not only in terms of improved lifestyle or quality of life, but also a stronger economy, more social stability. So that's what I mean when I say investing in a better community for the future. that's what we need to do.
Thank you. Caitlin?
Thank you. Another question that's coming in, what more can be done to help individuals address risk factors like high blood pressure, obesity, and type 2 diabetes?
Who wants to take that one?
Well, I say access, first of all, health insurance and utilizing it. These are treatable issues. And so the problem that we have is many people don't come in for treatment because they have no insurance or cannot afford it. And so that is one thing that we need to address immediately. That is one of the things in the political arena that's right now being debated. We need to see that whoever is president after November is really committed to seeing that access to health insurance is more broadly available. The Affordable Care Act has provided insurance for 20 million people, but we still have another 30 million people without insurance and others who are underinsured. So we need to make sure that access to available services really is there for everyone who needs it.
Sudip, I'd just also add that, in situations like this, it's interesting to think about double and triple solving issues. So if people are coming into contact with the healthcare system for testing, for their care, why not at the same time as is possible, also speak to underlying conditions like your diabetes management after your recovery from COVID and your hypertension, that this is not, you're not a disease in front of us. You're a person who has, other conditions that are in play that need to be well managed so that your health is as strong as it can be going forward. And so that, as Lou was saying, your health can be your wealth to yourself, to your family, and to the community more broadly. So I think taking advantage of those touch points with healthcare, with public health, with health services, a consequence of COVID, and building on the other things that the patients need truly so that their overall health is advanced rather than a single effective treatment, hopefully, and recovery from COVID alone. So taking advantage of that, I think, is very important.
Thank you. Yeah, taking advantage of every engagement.
Yeah.
All right. I think we've hit the end of the questions, Caitlin. Is that right? All right.
I'll let you.
Thank you. Well, very quickly, this has been just an incredibly engaging conversation. I do want to walk away with something concrete, though. So very quickly, with a laser focus, if I could ask you to answer the question, what should we be doing now, this week, this month, to reduce disparities in the COVID-19 health outcomes? We're in the middle of this. This is the time for answers. And I know I'm asking to be quick, but please, Vivian.
I think better communication and understanding, as Dr. Sullivan pointed out, we need to stop thinking about changing the populations, but really thinking about systemic change, organizational change to be more accommodating to the diversity of individuals that we have, and providing hope instead of such a negative message, providing hope to encourage all peoples in this country to seek medical care, to seek testing, and hopefully to participate in vaccines so they can be assured that the results of the studies of the vaccines will be helpful. And if not, they'll know not to participate. I'm just encouraged that there is attention being given to all of these factors now. Thanks.
Thank you. Elena, one thing. What should we be doing?
I think it's having a family approach. We've, in our communities, the Latino communities are so different from the East Coast to the West Coast. And we have mixed families with undocumented in our families and farm workers in our families. I think a family approach that families are respected and the parents want their children to get ahead. They want them to be healthy. And in our communities, we need to I totally agree, we need more communication targeted to our poor communities, especially those who don't have the education or the health literacy. They need to understand in plain, simple words and social media, et cetera, on how to be part of a functional economy in our country, and that we all respect and love each other. But we need them to step up and to be part of the community too.
Thank you. Patty, one concrete step.
I'm picking up on what Elena said about really culture in our communities. One thing that we have done is we've looked for unusual suspects, unusual partners that tap into strengths within communities. So we created a partnership with Hip Hop Public Health, who created 2 very powerful videos, 20 seconds or more, about hand washing and other mitigation pieces. And we also did 20 segundos o más for the Latinx population. And really, the uptake on that has been extraordinary. And also what we have learned about health behaviors changing as a consequence of it, and the true understanding by populations about this. So the hip hop community is enormous. It extends well across many different demographics, and we all need this information. So we're very part of that partnership. It's just one example.
Thank you, Patty. David, one thing we should be doing right now.
It is not enough that the American public now understands the disparities exist. We need to help them identify and understand the systemic factors that produce them. And our challenge is, how do we tell the stories of our disadvantaged populations in ways that emotionally connect with the American public, so that there will be political will to say, not in our country, we will not tolerate this.
Yes. Thank you, David. And Lou, I'd like to give you the last word.
Yes, I think we have an opportunity really to do a major effort to try and educate the public about the quality of science. I was pleased, for example, that the pharmaceutical industry of the companies made the statement to the public: they will not release a vaccine that has not been thoroughly tested and they can stand behind. We need to have more statements like that. We need to mobilize our health profession students and our professionals to work with organizations in our communities where there is trust, where there is communication, to really meet with our citizens where there are questions, where there is distrust, and really explain that to them. Because there's been so much confusion over the past few months about this, that I think anything that we can do to bring clarity and trust to the system, that's very important, not only for this current pandemic, but for healthcare in the future. Because healthcare, as you know, it's a very personal issue. People will not utilize the system if they don't trust it. We need to do everything we can to make sure that it's transparent, that it's understood, that people feel empowered to ask questions and be part of the process of designing and participating in their own health care. If we do that, I think that we'll have a good outcome from this, but it will require an ongoing effort, and I think all of us have our own roles to play in that.
Thank you, Lou. My thanks to this incredible panel. Building trust is job one, and you all are just, people will trust you and follow you. So the community, you have your charge, you have your leaders. Let's make a difference in addressing health disparities. Thank you. I'm going to turn it over to Jenny. Thank you all.
Sudip, thank you. And thank you to our panelists. It was a very powerful, excellent discussion with some very actionable steps, and we need to get to it. I am particularly pleased to introduce our next two 23-1 segments. Scott Whitaker, who's the president and CEO of AdvaMed, and Lyda Hill, the founder of Lyda Hill Philanthropies. They have followed different career paths, but they've each contributed in critically important ways to the same goal. That is, delivering new solutions to patients who have been waiting for just too long for these solutions. If you're enjoying today's programs, please know that we host both member-only and open to the public programs, much like these, all year round. To learn more about Alliance membership, visit the Research America booth on our conference site.